start the record? Oh, perfect.
Yes.
Perfect.
Thank you.
Perfect. Thank you, Professor. I will just start our presentation, and in a few seconds, I will give you the word, okay?
Please.
Okay. Hello, everyone. Here is André Schmidt, the current editor-in-chief of the Brazilian Journal of Anesthesiology. As you know, in addition to the publication of scientific manuscripts, the Brazilian Journal produces additional content for social media platforms, podcasts, brief videos, online lectures, and live webinars, always seeking to disseminate articles published by the journal and discuss relevant topics within the scientific and editorial process. Today, we are going to have a special event, a recorded online lecture, and the speaker is Federico Bilotta, Professor of Anesthesiology and Intensive Care Medicine at Sapienza University of Rome, Italy. The title of his lecture is Fraud in Clinical Research, a Relevant Problem in Perioperative and Intensive Care Medicine. This is an extremely relevant topic, and it's really a great opportunity to learn more about it and perform a deeper discussion on the topic. I would like to read a couple of words about the main background of our speaker. Professor Bilotta has a master's degree in medical bioengineering, residence in cardiology with special competence in transesophageal echocardiography, residence in anesthesiology. He's a PhD in cardiorespiratory medicine. He's a full-time attending anesthesiologist at the Department of Anesthesiology, Critical Care and Pain Medicine of the Sapienza University of Rome, working in neuroanesthesia and neurocritical care in the last 15 years. From 2008 to 2012, he was a professor in clinical anesthesia at the Albert Einstein College of Medicine, New York. He has also been an invited professor in several universities all around the world, author of more than 250 scientific papers, and peer reviewer for the most important journals in anesthesia and critical care medicine. Professor Bilotta is a member of the editorial board of the Journal of Neurosurgical Anesthesiology, Journal of Neurocritical Care, and also of the Brazilian Journal of Anesthesiology. Since January 2022, he's chair of the National Anesthesia Society's Committee of the European Society of Anesthesiology and Intensive Care. Hello, Professor Federico. It's really a great pleasure and a great honor to have you with us today. Thank you so much for your participation, and feel free to share your presentation with us. And thank you so much for your attention with us and your and the possibility to have you with us today.
Thank you so much, André. It's really a pleasure. I think that the cooperation with the Brazilian Society and the Brazilian Journal of Anesthesia is among my priorities, and I do have a lot of friends and esteemed colleagues in your community. Today, we're going to touch a very sensitive topic because fraud in scientific publication, it really is a way of biasing the credibility of our results and eventually to harm our patients. And to introduce this topic, I want to mention the sentence, the state of Philottete that was fighting to conquer a magic bow. And he says, in this 500 years before Christ, Sophocles' tragedy is rather good to fail with honor rather than to succeed with fraud. And I think this should be the driving philosophy we should respect. Is fraud a problem? This is the first question. This is a report published in 2017 from Retraction Watch. It's a website dedicated to this team, to this topic. And as you see, the issue related to various forms of forged information is really exploding. And this is related to the tight connection between the so-called publish or perish publication-related career and even some of economic interest in the companies that are active in medicine. This is the report, and as we see, there are several authors and several topics and several countries represented in this inglorious list. But what I would like to point out with you is that the first two positions of this top 10 list are occupied by anesthesiologists, intensivists. This is extremely sad. If we compare to other specialties like oncology or cardiology, the number of publications in our discipline is relatively limited, but unfortunately we hold the top position for forging and fraud. We will go through these topics in some detail, and we will see what happened in the past and what can we do in the future. So as I anticipated, unfortunately, we have some worldwide recognized championship in the field. The first one, in terms of retracted papers, is a Japanese colleague, and he's the #1. And he published, Fuji published several papers that supported the potential or the reported benefits of one drug that prevents nausea over others, but basically the reported results were forged. And as you see, the forging process was recognized because the analysis of details of the reported data proven that there was no random noise in the distribution of very simple clinical data like age, blood pressure. So he just wrote the same blood pressure throughout the same number, there's several numbers, and that's it. And in Karlslice, one of the editor of anesthesia, now among the top journal in our discipline, identified how the standard comparisons reported by Fuji's paper were not realistic. The second colleague that has the highest number of retracted paper made a much more serious impact on our discipline, because Joachim Bolt became also chief editor of Anesthesia and Analgesia, and it was also in the editorial board of several other extremely prestigious journals in our discipline. And what is interesting is that this story lasts almost more than 3 decades now. And he started with an initial publication on the clinical use of hydroxyethyl as a starch. We all remember, we all know the great pressure that was delivered over time to promote this drug. Of interest, it was afterward reported that there were doubts on the safety of this substance, and possible concerns on the impact of renal function dates back to 2001. Afterward, the initial evidence on the potential risk associated with the use of this drug, Bolt produced even more feedback comments, some of them published even in the Lancet. But afterward, it came clear that there were the potential drawbacks, the potential risks associated with hydroxyethyl starch uses do not only limit to the renal function, but extend to a potential interaction with the coagulation abilities. And the story continued over time, and even though some evidence on the forged data emerged, the proof of a consistent and reproducible risk associated with hydroxyethyl starch only came in 2013, when a higher mortality and higher risk of kidney injury was proven in intensive care patients. This was not enough to close a long series of lies, and it also became clear that there were substantial implications for patient safety. At that time, both the FDA and the EMA agency raised concerns on continuing the use and distribution of this substance, but only limitations to the indications were introduced in clinical practice. This was 2018 already, and we are talking about a substance that has the potential to increase the mortality and renal damage. It's not enough. Afterward, several other papers continued to come out, eventually spontaneously, as reported by the authors, with no solicitation by the companies. And in 2018, a German group published a paper, again in anesthesia and analgesia, and with the intention to prove the absence of a possible renal effects. In the same paper, as I have highlighted with a letter to the editor, they reported that the perioperative use of this substance was associated with almost a double of intraoperative bleeding, so proving a substantial interaction with the coagulation abilities. After this controversial evidence, a group of experts came out with a public letter that highlighted a problem that I would especially underline today. The commercial marketing strategies of the producers, once the FDA and EMA have limited the access in Europe, might be distributed into low-income and developing countries. And this is exactly what happened. And this is one of the reasons we are reporting this data today in your society. So more evidence since then continued to emerge, and several of these studies were accomplished in non-humans models. And I'm not sure if what can be true as a possible beneficial effect as proven in an ovine like sheep model might not be true for humans. And at the end, in 2019, the Canadian Journal of Anesthesia published a very clear paper that concluded how there should be a benefit, not only the lack of harm when we prescribe a substance, and beneficial effects of using hydroxyethyl starches have never been reported. We are step in proving the possible lack of damage. So several studies were continuously produced, and none of those proven any benefit. In July 2022, the European Medical Agency finally closed, at least in our area, the possibility of marketing hydroxyethyl ester starch in Europe. As we said, this is not a finished story, and as we see, there is a continuum of evidence production related to this substance that has substantial concerns on safety and no reports on clear benefits. The third classified colleague active in anesthesiology is Dr. Rubin. He reported the results of COX-2 inhibitors. Most of us, we are already aware that nowadays that the use of these drugs in patients presenting with coronary disease exposes those patients to an increased risk of death and cardiac complications. What is interesting is that he came to publish those results without reporting a personal relationship with the producer. And even more interesting, it came out that some of the co-authors never signed the consent for submitting the patients, the reports, the studies for publications. So Dr. Rubin is the only one of those authors that I've mentioned so long that have been condemned and recognized guilty, and a substantial fee was committed to him, and he was suspended for clinical and research activities. Anesthesiologists are not the only colleagues that produce evidence or produced evidence that are relevant in perioperative medicine. Also, Dr. Poldermans is involved in a very sensitive story, and this story has involved the European Society of Cardiology and himself as a chair of the preoperative risk assessment for non-cardiac surgery of the European Society of Cardiology. What is interesting is that in a paper that he co-authored, where claimed the possible benefits associated to perioperative bisoprolol use, but these evidence were proven not to be collected in real practice. And so data fabrication was part of the process, and even the diagnosis of acute myocardial infarction was falsified. So you understand that on this background is the process of producing guidelines is strongly biased. And subsequently, a meta-analysis proved that there was a forging process behind the Poldermans data, and perioperative use of beta blockers in non-selected patients associated with the potential for increased mortality. An additional note on Poldermans' case is that there are some journals, and in this case, I'm especially referring to New England Journal of Medicine and Journal of American College and Cardiology, refused to retract, decrease the papers, even after it was proven the falsification of the data. So you see how complex is the whole picture. Is there any room to intervene? And this is the question we should address. Certainly, an ethical, individual, and group concern might play a substantial role. a careful and sensible environment is the first guarantee of the quality of produced evidence. As we mentioned right from the beginning of the lecture, the integrity and misconduct in the field of producing science, specifically in the field of anesthesiology, is a continuous threat. And this is a paper published in Anesthesiology 2021 that has specifically addressed this evidence. What I want to mention is that often the scientific misconduct associate with other non-appropriate behavior. And this includes bullying within the same research group, and sometimes even acting against members of their own team. So the fight against scientific fraud should be really a priority for all the people, all the colleagues involved within the field. This is a very recent paper that highlights how in some environment, the risks associated with poor quality of scientific evidence becomes epidemic. For those that are interested, and we are all interested in the field, I suggest to register in Retraction Watch. And this is really a source of information, and it generates a lot of understanding on the underlying process. In conclusion, what is behind fraud in science? And this is certainly individual ambitions and greed. There is a possible role of the companies that intervene in our clinical practice and produce drugs or tools that we do use. There are some responsibilities that lays on the editorial process. So journals have an important role in the whole issue, and certainly the control authorities. As I mentioned, both the FDA and EMA have delivered some statements over time, sometimes with a substantial delay, even almost 20 years. But they should vigilate with a more tight approach. And the scientific societies should promote initiatives to validate reported evidence. What we see in a single center do not have the same relevance if proven in a multi-center project. And another actor in this whole field are the eminent researchers. You know, we all tend to listen to famous colleagues and recognized colleagues, you know, but as I reported a few slides above, not them all are always clean in reporting what they are saying. So we should keep an eye on this and adequately address conflicts of interest when eventually exist. And there is another part that can play a role, and are consumers. In our case, we should call them with the appropriate word. Our consumers are the patients. And getting back to ancient Greek, the word patients means to suffer. So they do deserve a double respect. And the vigilance of the patients community should play part as in kind of informed consent process. It's interesting to notice that over time there were some changes on the characteristics of individual fraudulent authors. And is it possible to recognize those patterns and eventually verify when there is the suspect of forged data? As we understand, and I'm about to conclude, the issue of fraud in scientific science and publication is extremely serious, is booming, and is especially relevant for our discipline as perioperative medicine and intensive care medicine. Thank you for your attention.
Great, Professor. Thank you so much for your amazing presentation. It's really exciting topic, and your presentation is really amazing. Thank you. Firstly, I would like to ask you a few questions about the topic. One is exactly related to one of the topics that you commented in your take-home message, that is related to our ability to detect data manipulation and fraud in general. When we receive the manuscripts and the data from authors in our journal, for example, it's usually hard to analyze the data and really find any suspicions of data manipulation. Do you have any how can I say, any idea or any strategy that you can recommend for editors and reviewers in general to detect data fabrication or even manipulation of data?
Thank you, André. This is of course, this is a crucial element, and at the same time is a very sensitive topic, as you know. But let's say that I do have some insights, and I will try to step into this issue, of course, without or trying not to offend or alarm anyone. But I'm participating to the review process since almost 3 decades now. I'm a very advanced age person. And it made me sensitive to some spiking in scientific production. There comes a time when you see that a certain tool is under the light of attention. I'm saying a tool, or I might say a drug. There is an editorial I've been invited and published in The Lancet in July 2021 that specifically addressed one of those possibly controversial drugs. And you see, when you have new drugs that cost a lot of money, or new tools that cost a lot of money, and you see a spike over a few months or a few years on the production, and the production comes from certain countries of certain groups specifically, then you have to point out your attention. Then you have to increase your level of suspicion. And this is not immediately easy, but get at run after a few months. So you might have 4, 5, 6 publications that comes into the ground, but then you see, I'm sure that you have a constant exposure, not to every single paper of all the journals in our discipline, but to the titles of the majority. And so you see how it goes. And you see, you know, popping up here and there publications that are all addressed to the same direction, all saying, this is so good, this is so nice. Then you have the answer. I hope I was clear.
Great, Professor. Sometimes, for example, when the data is so good to be true, is, of course, a matter of sometimes of investigation. And it was the case of Professor Joachim Bolt, exactly. I think, as far as I can remember, the first letter that was addressed to one of the editors was exactly related to the incredible effect of one of his interventions in cardiac surgery. And so it's a way that we can detect by analyzing the publications, and these spikes are really a strategy, a very good comment. And
but
I think
can I say something on this?
Yeah.
You know, and in the case of Joachim Bolt, it's interesting because over a certain amount of time, it came out that he published overall data from approximately 5,000 patients. And the whole issue came out because FDA contacted the hospital and asked, how many patients did you have in the ICU in this period? And they only had 3,000.
Yeah.
You know, so it's not necessary to pick up the individual number of forged blood pressure, but the big numbers tells you something.
Yeah, perfect. We had, for example, recently some papers that were published in the Brazilian journal. In the last few years, I received some comments from authors asking for additional investigations in specific manuscripts. I think around 6 or 7 manuscripts, and we did perform an additional investigation following the COP guidelines. And usually, I think most of authors, they were initially reactive to the investigation. Is something that you really said that is very sensitive to authors, but I think everyone should be open to this investigation.
Absolutely, this is important.
Be prepared for the investigation. And
we should make it
even
clear.
famous, for example, one of these colleagues who was relatively famous in the area of anesthesiology, several publications, and even in high impact journals. And he was very reactive once when I really sent him the initial questions. And I think the whole message is that we should be open and be prepared for this investigation, especially with your data set organized and the analysis of data set. What do you think about that? For example, asking authors to share their original data set. Do you think that this is a good strategy to detect and analyze the data, avoiding or detecting manipulation?
Well, I think that a preliminary step is to clarify, if you are interested, we can produce something on this. As I said, from what I understood, you had the series of lectures on this topic, and I would strongly suggest the Brazilian journal to produce kind of a dedicated issue, you know. And in this issue, we might prepare a commentary where it should be clear that for each author, we do not only participate in the process of creating evidence on this specific subset, you know, neuroanesthesia, postoperative delirium, but every paper contributes to the process of creating a culture. So the culture of science, the culture of verifying an hypothesis is the highest value behind a paper. For this reason, the authors should be part of, should feel that explaining their methodological and data acquisition process is part of creating this culture. So I think is important, would be important, as I mentioned in my conclusion, that starting from the authors, it should be clear that you do not only give an additional number on the specific paper that you are publishing, but this paper is part of the larger picture of progressing of science.
Perfect, Professor. And one additional question. Last month, we had a live webinar with Professor Ben Moll from Australia, addressing a similar topic, just how to analyze the data and detect suspicions of manipulation and data fabrication. He shared with us some examples in the literature of comparison between tables and results from different manuscripts, and it was very interesting. And one of the findings that he shared with us was related to the incidence of data fabrication and data manipulation in clinical science in general, and he informed us that most of data manipulation and data fraud is related to clinical trials, much more than observational and other types of studies. The incidence is really high in when we consider clinical trials, especially when we analyze positive results in clinical trials. What do you think about the registration of clinical trials, and especially the prospective registration of clinical trials in official platforms? Do you think that is nowadays essential to be obligated by all journals before any publication of a manuscript, or do you think that is something that is not effective to reduce data fraud?
Yeah, in the previous question, you also asked me about the data analysis and the details. Now, another approach is, of course, registering prospectively registering the trial. All of these measures can take part of the process, but I think that there is a relatively simple question behind, and is, where are the money? If there is an individual interest of a certain individual author to build up his own CV, to make a career, you have to understand it. And this is possible, somehow is possible, because our world is relatively limited. We are all in close connection, you know me, I know you, I might know another person that knows him. So we got to understand where, and this is an easy example, but of course, if we think of potential trials that address or are intended to prove the beneficial effect of something costly, a monitoring system, a drug, an approach, so ask yourself, where are the money? And when you register a trial, I think that the most important element is this one. Who is going to pay for that? Because if there is a company that directly pays, sometimes it's even clearer. At least we know. But I barely believe that you can run a prospective randomized studies over 500 patients just by yourself and prove that a certain drug is beneficial without having any economic support from the producers. If this is reported, then something is not clear.
Yeah, that's true, Professor. Thank you. And an additional question, we are going to enjoy the time with you, with your knowledge about this topic. My question is related to the bias of publication. Of course, we know about the bias of publication in terms of positive and negative results, both in experimental science and clinical science. Do you think that data fraud and data manipulation, what is the real impact in our clinical practice? Is there any estimate of the impact of data fraud in clinical practice, as we have with a publication of positive and negative trials? I remember to read a New England paper some years ago about the effect of antidepressants when you analyze the bias of publication. And this study was really a seminal study on that topic, I think almost 20 years ago. And I remember that they showed that at least 30% less effect when you put together positive and negative trials, the negative trials that were not published, but were registered in registration platforms. When you put all the results together, it's around 30% less the effect of most antidepressants when you treat major depression. It was an example. What do you think that is the impact of data fraud in clinical practice?
This is an extremely interesting and only partially addressed issue. I would like to suggest a reading. A short book is entitled Painkiller from Barry Meyer, and is a very interesting story on a drug that is of somehow interesting for us because it's an opioid intended for chronic pain. And the author, Barry Meyer, also reports the story of the company that produced this drug, and how in the late 60s and beginning of the 70s, they included in the marketing strategy an individualized prescription scoring. So every doctor was monitored for scoring a certain drug or using a certain prescription, you know. And this is the way they promoted, you know, by giving something back to the one that had the highest score. But unfortunately, as we have seen in the COX-2 by Reuben report, unfortunately, the excess of prescription has been recognized as one of the causes of opioid epidemics that is now lambasting the United States. You might know that opioid toxicity turned into be the first cause of death among the younger Americans, higher than car accident and shooting. So what we are paying, or what we are making our patient paying, is a death pay, and is a death condemn in some cases. And I think that when we condemn to death for inappropriate beta blocker uses, inappropriate COX-2 uses, inappropriate opioid uses, even when that is too much.
Thank you, Professor. And one last question to you is related to the comparison of clinical science, clinical studies, and experimental studies. And you said about STARS, for example, we have strong data related to experimental studies and very weak data in clinical studies. Do you think that perhaps data fraud in experimental studies is one of the reasons that for several kinds of therapies that we have very strong positive findings in experimental studies and any positive effect in clinical studies. Do you think that perhaps data fabrication in basic science is one of the reasons of that?
The answer is yes, just to make it clear. I think that what happens in humans might be different than from what happens in elephants. And I don't know if elephants are good examples of preclinical science, you know. So, of course, preclinical research is important. Of course, this should be the background. We cannot start our experiments in humans, but we should understand that human system is much more complex. So can you imagine what is true in a rat model, in the brain of a rat model, doesn't necessarily apply to the verbal language of our brain? You know, we cannot study the impact on ideation. We cannot study the impact on chronic neurodegenerative. You know, there are so many, and the example is, as we said, starches are positive in microcirculation of a fine model. But are we veterinary? If we are veterinary, then it's okay. If we are doctors, then we are doctors. I mean, it depends. Who are you curing, and who are you taking care for? I mean, would you bring your car to the farmer saying, can you fix my car? No, that doesn't make sense. And this is what we have to prioritize. Evidence in human research will give us additional insights.
Perfect, Professor. And thank you so much for your presentation. Do you want to make any final comment to our audience?
I want to say something. You should all know that when you have a doubt, when you have a question, there is someone you can address. I will be certainly always available, and there as my email contact. If you have a question, if you have a doubt, don't stay alone. You think something, say something, and this might be the trigger for a step forward for the entire community. Stay together. I mean, this is what a community is intended for. Thank you so much.
Thank you, Professor. And I really, in the name, on behalf of the Brazilian Society, I really would like to thank you so much for your contribution to the journal. It has been really great to have you with us, contributing, doing your excellent peer review, and participating even in our editorial process, contributing to the journal and publishing manuscripts, really outstanding manuscripts. And I really would like to thank you so much for your great contribution to Brazilian anesthesiologists and the Brazilian anesthesiology in general. Thank you so much. And
my pleasure.
See you
Stay
next time. Certainly we will stay in touch.
Thank you. Bye-bye. Ciao.
Thank you. Professor, I'm going to